Hi, today I'd like to share a case study with you. And the reason why I named this video with a series of symptoms, because I hope after this video, if you encounter the same combination of these symptoms, you may think of what diagnosis it is immediately. So as usual, we start with a case study. We have a 70-year-old man present with haematuria with left lung pain. He reports the symptoms start 2 months ago during a visit to India and have been progressively worsened over the past week. He also reports gradual weight loss and reduced appetite with non-productive cough. And his past medical history include type 2 diabetes, hypertension, hypercholesterolemia. And the physical examination shows his body temperature is 37.8 degrees Celsius and his hemodynamically stable. And for the abdominal examinations, and we find there's a swelling in the left scrotum and it doesn't empty while lying flat. The abdomen is soft with normal bowel sound. And that's also fine. We also find there's a bilateral swelling looks on both sides. And the urine dipstick showed a pH of 6.5, positive blood trace with plus, and positive trace for protein, leukocytes, and nitrate. And we also ordered a chest X-ray for the patient and find multiple rhinopathy in both lung field. And before I tell you what is the diagnosis, let's look at what points that help guide you to the differential diagnosis and the definite diagnosis. Firstly, we have elderly here, and he presented with frank haematuria, which means he likely to have a renal disease and left lung pain. At this stage, you think of whether any inguinal related to inguinal hernia, as we find there's a swelling in here, or is there's an infection, or there's a post-renal, or it is a intrarenal, or this is a pre-renal disease. But in this stage, we still need more clue. So we also find he had a travel history, visit to India. At this stage, you may think about if this is IgA nephropathy or post-streptococcus glomerulonephritis, but please remember that IgA nephropathy is present days after the infection, and post-strep is present weeks after the infection. In this case, it's 2 months ago, so it's far away. So I mean, it's too long. So you may cross out this different differential diagnosis, and then he also report that gradual weight loss and reduced appetite with non-productive cough. And this one, I hope, raise your suspicions, especially in this old man, because if there's unusual and normal weight loss, and you think of there's a cancer. So although this one, you find a swelling in the left scrotum, it doesn't empty while lying flat. I mean, this is also a key for diagnosing the inguinal hernia, but this is very unlikely in this case. But you can post out this differential diagnosis by performing an ultrasound. But in this case, this is a very important clue. It's a clue for you to guide you to know this is likely to be a left renal cell carcinoma. It must be left. Then you ask me why it's not right, and I'll explain it later. But let me finish this page first. Then you find this bilateral swelling looks like both fine, and this might be because of the renal disease. Because it's in this case, because there's a decreased renal function, and it might be a decreased renal function in this patient, so it causes swelling. And then, I mean, 4 plus blood is, I mean, there's not even need to explain. I mean, this is absolute red flag. for DuPont due to be a renal disease, and it is also very common in renal cell carcinoma. At the chest X-ray, we find there's a multiple line opacity in both lung fields, and this is not a good sign because it might present as likely to be metastasis to the lung from the kidney to the lung. It's rather be like at this point you have to think about the primary carcinoma is from the lung or from the kidney. So this is what we have to consider. But anyway, as I mentioned, why this has to be a left renal cell carcinoma, you understand it by looking at this anatomy image. Let's look at the right side first. The right testicular vein is directly drained into the inferior renal cava, but the left side, the left testicular vein is drained to the left renal vein. So if there is a tumor or a mass or thrombi here, it is block the blood drainage, so the blood accumulate back to here, so cause a swelling here. So in this case, combined there's some old man, he showed gradual weight loss and he got a non-protective cord and yeah, and he got this swelling. It's very, very high chance for him to have a left renal cell carcinoma. So to confirm it, we have to order a series of tests for it. And here this is the diagnosis, and I have a very, very simple description for it, and I'm not going to go through it. So you may have a look if you're interested. But for the differential diagnosis here, like I mean, by looking at the history, you can already cross out most of them. Here, you can cross out by you see if there's any symptoms related to the hormonal change, or you can order a morning crostal test for it, level test for it, to express this diagnosis. But according to the case description, this is very unlikely to be this one, and this can be cross out by all the imaging tests, and this one also, and tuberculosis. I mean, this is high chance also, but like because it you already ordered a chest X-ray, right? So we didn't see any specific TB sign on the chest X-ray. So this we can cross out already, and others there's others you can cross out either by biopsy or look at the imaging or by lab tests. So what we're gonna do is the imaging is a very good is like a golden standard for you to diagnose this renal cell carcinoma. And then the initial and golden standard is the CT with contrast. The other one is CT radiography. But if the patient cannot take CT, the alternative is MRI. Even though MRI is expensive and time consuming, but there's good, like there's advantages of it is to detect the renal vein or renal cava thrombi. So what if there's not a cancer, there's not tumor, but there's a thrombosis there? So you may order MRI to check on it. So since the patient show the respiratory symptoms, non-productive coughing, so we also order chest X-ray or CT chest to see if there's any lung metastasis. Because for the RCC, renal cell carcinoma, there's very common and high chance of them. I mean, not like if they got the metastasis, they're gonna go to the lung. And also, if the patient complain of bone pain or you order test to find there's an elevated ALP, then you order both test post scan. And if the patient present some neurological symptoms like headache, confusion, or other stuff, you can order a CT head. So the imaging are very critical for your diagnosis. Still, you have to order some lab tests, but I didn't put in my slides because they are not as specific as for you as imaging. But yeah, but they are. I can't say they're not helpful, but they're just not specific. So the lab test you might find as a normal hemoglobin level. So because like if there's decreased renal function, and then the kidney is responsible to produce the EPO, the erythropoietin, so they're gonna be low, present with anemia, and so the red blood cell or the the platelets may increase because there's gonna be a perineoplastic stimulations of bone marrow activities, or that there's as a result of systemic inflammations, and you may also find hypercalcemia. So, but they're also caused by the perineoplastic symptoms, or they're by lytic bone metastasis. So if they spread to the lung, so they cause the breakdown of the lung, of the bone. I'm sorry, if they spread to the bone, they cause breakdown of the bone tissue, and they cause hypercalcemia. And they also have increased ALP, as I mentioned before. So yeah, this is what happened in the lab test, but still, the most important thing for your diagnosis is the imaging. So for the treatment, when there's tumor, you always think of the surgery. So there's particle nephrectomy or radical nephrectomy. So the actual indication for particle nephrectomy is T1, which means the tumor is the size of the tumor is less than 7 centimeters, or there's a young patient or the patient with lifelong expectancy. You would like to preserve as much as kidney function for renal function for them, or the patients have comorbidities that impact the renal function, such as hypertension, diabetes, or other systematic autoimmune disease such as SLE, lupus, or other stuff that will impact on the function. So you also like to preserve as much as the renal function for them, or if there's a multifocal mass. I try to look at why this is the multifocal mass is why this is one of the indication. Some claim that, let's say here you have many mass here, so you cut them separately. So I mean, at the end of the day, you have very less kidney tissue left after the surgery. So some suggest that it is like the same result as radical nephrectomy. Why don't you just do a radical nephrectomy instead of a full radical nephrectomy? Still try to preserve some kidney tissue. And this is what I read from their research. But anyway, this is one of the explanations. And so for the radical nephrectomy is a large tumor, which is larger than 7 centimeters, or those with increased oncological risk, such as after the biopsy, there is a very high aggressive histology. Oh, so yeah, since I mentioned about the biopsy, previously some said that the kidney biopsy before the surgery is dangerous and is contraindicated because we scared of the infiltration or the metastasis of the cancer cells. But according to the latest textbook I read, they suggest that this is not as high risk as we thought, and this is a very useful procedure that help us to know what is the histology of the tumor, and they suggest we should perform a biopsy once we find there's a tumor. So I think it depends, because every year there are new research that is good or not. So I think it depends on your supervisor, your hospital, or your local authorities. So anyway, the radical nephroscopy, as its name, it remove the entire kidney and the surrounding greater fossa, which is here, is surrounding the kidney, and this fascia also cover the adrenal gland. So we also remove the fascia that's surrounding the adrenal gland, and we also remove the renal lymph nodes. And some guidelines suggest that we don't have to, and some will remove. And as I know, some surgeons, they like to remove the lymph nodes and send them to the lab to see if there's a metastasis. So and also to make sure there's no recurrence. So yeah, I mean, anyway, you can or do not have to remove the lymph nodes, and also remove the proximal half of the ureter. So for the medical therapy, there are some medical therapies provided after the surgery. There's a vascular endothelial growth factor inhibitor as a driven therapy after the surgery. And also there's another many combinations. This combination is for the patient with pure anti-VEGF therapy. And we also have immunotherapy for patients with advanced cancer. And we have different drug choice in different situations. And I'm not a specialist on this one, so if you're interested, you may look at the some oncology textbook or oncology research paper or latest guideline. But this, I mean, this one is I read that from a textbook, and I'm pretty sure there's still the drug choice now at the time I'm recording this video. But as I say, I'm not a specialist on this one, on oncology. So as I know, this one is still used. I mean, I heard others use this medication, but I'm not specialist on this. So if you're interested, you may look up on it. And for the prognosis, is after the radical or partial nephrectomy. So we send the tumor to lab. If the tumor confined to the capsule, which is stage which is T2 or T1 or T2, we have a very good 5-year disease-free survival rate, which is 90 to 100%. But if they're extending beyond the renal capsule, T3, T4, and it's going to be 50 to 60%. And if unfortunately find to be nodal positive tumor, that's going to be at 0 to 15% of 5-year disease-free survival rate. And this is the end of the case study sharing, and thank you so much for your listening.